So going now to immunogenicity and the impact of pegylation on immunogenicity. So immunogenicity refers to the immune system response to therapeutic proteins, which can negatively impact the clinical benefit-risk ratio. Immune response may neutralize the drug's biological activity, accelerate its clearance, or even cause adverse events, such as systemic allergic reactions. So when we look at immunogenicity, we have to look at immunological aspects of the therapeutic proteins. So when you have immunogenicity, we have anti-drug antibodies that can be humoral, mediated by B cells, or cell-mediated involving T cell responses. What is important here is that these antibodies may neutralize the drug, cross-react with endogenous proteins that are similar to the drug, or increase the risk of adverse events. This underscores the need for strategies to mitigate these risks during the drug development. So in order to avoid this negative impact of immunogenicity on pharmacokinetics and pharmacodynamics. So immunogenicity can lead to serious consequences in many cases. But what is important here is that when you look at the clinical sequelae, we can see that the impact of the clinical symptoms and signs usually is really in a low frequency. So we have more binding antibodies or PK altering antibodies. Then we can have neutralizing antibodies, but really the most impact is really when you have allergic ADAs or cross-reactive neutralizing ADAs. So we have examples of immunogenicity issues with therapeutic proteins such as in anemia, where we have this study where we can have immunogenicity against recombinant EPO when they were caused by neutralizing anti-EPO antibodies. But also we can have that in IBD for antibodies, for therapeutic antibodies such as infliximab. So to mitigate these problems, to have mitigation strategies, we can modulate the patient's immune system, the immune response of the patients. Usually it's not so well appropriate, but we can have immune suppression or immune tolerance induction. But we also can modify protein characteristics such as reducing administration frequency, removing these T-B cell epitopes, and shield the epitopes with extend half-life strategies such as PEGylation. So in this case is really what is the important point here is really to mitigate these factors that really can alter the protein characteristics in terms of a drug. So PEGylation can mask antigenic epitopes and reduce immune recognition by creating this hydrated shield around the protein. This really can potentially decrease immunogenicity and prolong drug action by reducing administration frequency and stabilizing the protein. So basically, when you have a longer half-life, you have this potential to reduce drug administration frequency. We might have this opportunity here to reduce the immunogenic responses. So PEGylation can sometimes trigger an immune response against PEG, against PEG or pegylated protein. So usually what we can have in many cases is an anti-PEG response that can be weak or may not cause adverse reactions. Usually this is against these small stretches of PEG, but usually when they have a long PEG stretch, a long PEG polymer, we might have a longer and more reactive immune response. So what is important here is that the anti-PEG antibody response may be increased when the protein is or a human protein that is deficient in the recipient or a high immunogenic non-human protein. So neutralizing ADAs against these PEGylated proteins may sometimes occasionally cause serious conditions, like, for example, in PEGylated thrombopoietin. And this the PEGylated thrombopoietin was discontinued after neutralizing anti-TPO ADAs that really caused severe thrombocytopenia in 30 patients out of 325 healthy volunteers, and also in patients treated with the drug. So this might occur in certain aspects of pegylated proteins that really can have developed this decreased efficacy due to neutralization, decreased bioavailability to the accelerated clearance, and cause these hypersensitivity allergic reactions. Another point which is quite important here is the impact of pre-existing anti-PEG or anti-drug antibodies. And this is something that we came to know in the last 5 to 6 years, is that basically some patients around, for example, 70% of the general US population have anti-PEG antibodies. And this might occur due to the exposure of PEG that happens through food, cosmetics, and medicines. And patients treated with pegylated drugs can have this contact to these pre-existing and induced anti-PEG antibodies. So this presence of anti-PEG antibodies may not always be clinical relevant, and this is really important to see in many studies where these anti-PEG antibodies that they pre-existed in patients that started therapy with pegylated proteins could not see an effect of an adverse reaction of a reduced activity of the drug. So the exposure to pre-existing ADAs is something that should be really analyzed and evaluated in these clinical studies with pegylated drugs. So the risk of immune response is really influenced by the unique properties of the pegylated proteins. So what we have seen from Professor Paolo Caliceti is that usually PEGs, they have different molecular weights. Some proteins have a high molecular weight and size that usually are associated with a higher reactivity. So the site of attachment and linker properties is also important. Usually we know that the conjugation to cysteine residues or terminal amino groups can cause less immunogenicity. We also have these branched versus linear PEGs that are really associated with enhanced immune shielding. The site-specific PEGylation also minimizes the exposure of new epitopes and ADA formation, and really PEG by itself is weakly immunogenic. The problem is that sometimes, and due to the technology, when you do conjugation with PEG, sometimes we can expose epitopes that usually are not present in the original protein. So besides this, we also have protein and patient-related factors that also impact the risk of immunogenicity. So we know that immunogenicity can be triggered by therapeutic protein-related factors, as I said before, due to the origin, the post-translation modifications, stability of the protein and aggregation, but also patient-related factors. So we know that age and sex is one really important factor that might trigger patient-related immunogenicity. The haplotype of the patient due to these genetics of HLA, the previous exposure to pegylated proteins might trigger the development of anti-drug antibodies against PEG, but also the fact that the disease, the concomitant treatments of the disease, whether the disease is chronic or the disease is autoimmune, we may also have here the possibility to induce these immunogenic responses. So, but the fact that we also have another characteristic, which is the drug administration and target factors, like dosing, the frequency of and duration of treatment. We know that probably subcutaneous administration is more immunogenic than IV administration, and also the target nature of the target to the drug, whether it is at the cellular membrane or if it is soluble. So all these factors might implicate immunogenicity. So we cannot say that immunogenicity comes from one factor, but is a multifactorial way of developing anti-drug antibodies. So now we have to monitor immunogenicity, and monitoring immunogenicity is essential, especially in groups or patients that are at risk, such as atopic patients or those which are pre-treated with non-pegylated proteins. So these ADA levels can be measured using various assays, helping to detect or the reduce efficacy or adverse reactions very early. So in this case, really what is important is to assess these ADAs in a regular way. It's not possible here to understand the development of immunogenicity if you just measure once a year. You really have to maintain the monitoring during 3 or 4 times a year, really to assess the kinetics of development of immunogenicity against any biological drug. So the measurement of ADA, we have screening assays that usually are done by direct or indirect ELISA. Usually we need to have a method that is really not implicated with the development of false positives or false negative results. Usually these tests must be tolerant to the drug. So it's important here that you don't have a high concentration of the drug when you measure anti-drug antibodies, and then you need to have a confirmation assay. So it's a screening assay, a confirmation assay, and then you can characterize the types of antibodies. And to characterize is really to do the titration of these anti-drug antibodies, titrate the immunogenic response, but also the neutralization to see whether these anti-drug antibodies neutralize not only the activity of the enzyme, but also the entrance of the enzyme in the cells, for example. So it's important really to assess the best ADA assays. So they should be tolerant, as I said, to the therapeutic drug. They should have susceptibility to interference by serum components. They should be really aware of that. The variable specificity of ADAs should also be done and assessed during the monitoring. The consistency of the ADA testing will allow us then to do comparable evaluation of the different results that the clinician is having over the years. So it's very important here that when you measure ADAs, you should measure several times a year, but it is also very important that the clinician can really maintain the consistency of the method that is being used in order to compare the results over the years. So further research is really important here and should address the remaining challenges to enhance this therapeutic potential of pegylated proteins. So more research is really essential to further enhance this potential of pegylated proteins, such as understanding immunogenicity. We really need to see the mechanisms why some patients have more immunogenicity than others. So the factor of the patient is really important to be a target of research. Also, other factors that influence long-term safety should be evaluated, and research on these long-term studies and understanding the impact of pre-existing ADAs is very important, because we need to understand whether the titer of anti-drug antibodies are maintained over time or are reducing over time in order to evaluate whether you are creating immunogenicity or if you are creating tolerance for that drug. So we need also to do research on optimizing PEGylation, develop new PEGylation techniques. There are several, as Professor Caliceti was saying, but we need really to invest more on maximizing the therapeutic efficacy and minimizing the adverse immune reactions in order really to have this personalized medicine that really tailor PEGylate design to individual patients.